WA Country Health Service, ACRA-WA, the Rheumatic Heart Disease Registry in WA, and Heart Support Australia. This is now 43rd webinar, I believe, which many you can watch either on the ACRA website, if you're a member, or on the Rural Health West link that Taylor will provide. So the original intention of these was to reach rural and remote people, health practitioners in WA, and we do have many from many parts, from the Pilbara, from the Wheat Belt, from Denmark, Geraldton, lots of areas today. But we also today welcome many Eastern states health practitioners. It's great to have you join us today, as this has been advertised on ACRA. So I'm going to start by acknowledging the traditional owners of the lands on which we meet. I am on the Whadjuk Noongar people's land, and I pay my respects to their elders past, present and emerging. I pay my respects to any Aboriginal people in the room today. I acknowledge that we must acknowledge the effects of colonisation to take steps towards healing. I recognise the importance of self-determination for Aboriginal people, and that we must stand beside them to restore pride in the present and the past so that we can inform and move together in the future. I also acknowledge the many Aboriginal people who I work with for their courage, their resilience, and their gentle spirits. So it gives me great pleasure today to introduce a good friend and colleague of many, many years, Tracy Swanson. Tracy is the clinical nurse specialist at Hollywood Private Hospital here in Perth. Tracy has way more than 20 years experience in cardiac rehab, I think, has sat on the national executive, is a Heart Foundation and a Heart Health Ambassador, and has won the Clinical Excellence Prize for Acute Care Nursing at the Nursing and Midwifery Awards a few years ago. Tracy, I can attest to her clients, patients, her people, they love her. So I'm going to pass to Tracy to speak about sleep and cardiovascular disease. I ask if you have questions to pop them in the chat. You can raise your hand and come off mute if you feel it's appropriate at that time. Otherwise, Tracy will answer your questions at the end. Thank you.
Thank you, Helen, and thank you for the opportunity, and welcome everyone taking your lunch break to listen to me. I'll just highlight this is my first time of doing a PowerPoint through this medium, and the last time I presented this was at ACRA. I was asked to do a study or a presentation workshop, and I think that's how it came about for today, is from following on from the feedback of that workshop. So I'll do my best to share information. Please don't think of me as a sleep guru, because I'm certainly not, but I'm incredibly passionate about including sleep in every one of my cardiac rehab clinics. So we'll work through together. We had some basic objectives before, but we'll just go through a little bit on sleep, the stages of sleep, how it affects our health. I've got 2 case studies, which I think is important so we can look at different aspects of sleep. In a workshop scenario, a lot of interaction, but I'll do my best that you've come away with at least one thing for your cardiac rehab clinics, which is the most important. So very boring, but important that we define sleep, a condition of body and mind that typically reoccurs for several hours every night, in which the eyes are closed, the postural muscles relaxed, the activity of the brain altered, and consciousness of the surroundings practically suspended. Sounds quite magical. So sleep, it's a fundamental element of good health, and it plays a crucial role in preventing heart problems and maintaining overall cardiovascular health. And poor sleep affects our quality of life, and it increases the risk of developing and aggravating our chronic health conditions that we all care for patients with. So they'll include our heart disease, our diabetes, our stroke, and very importantly, our mental health conditions. So sleep health, and when it's poor, it often then flows on to an issue with poor diet and low physical activity. And then in our cardiovascular rehab roles, we know that once again influences cardiovascular risk. So sleep alongside our diet and our physical activity is a very important pillar in health. So there's 3 important pillars that we should always consider: our nutrition, our sleep, and our exercise. And obviously our emotional well-being is very important as well. There's stages of sleep, which probably sounds a bit boring, but let's just simplify that so you have an understanding of what's going on for yourself and maybe for your patients. So simplified, it's awake, light, deep, and REM. And we'll go through that. There's 4 REM stages: REM 1, REM 2, REM 3, and then REM. So let's look at REM 1 to start. So REM 1 is the stage of between our wakefulness and our sleep stage. And we're thinking about cardiovascular health. So at this stage, our heart rate and our respiratory rate begin to decrease. Our eye movements become slower, our muscles relax. That's when you might get those twitches that we've experienced. I certainly have in the past. It's a very short stage, 1 to 5 minutes per cycle, and it only represents about 5% of your overall sleep. So this is your lighter sleep and can be very easily disrupted. Sleep 2. Now, this is the important one, because if you guys want to nod off during this presentation, you want to do it for this amount of time. That's just 20 minutes. So REM 2, consider it as light sleep. It's before we transition to deep sleep. Our heart rate and respiratory rate and muscle activity once again decrease. Our body temperature drops. Our eye movements cease. This is the longest stage. It's about 50% of total sleep time. So REM 2 is the 25-minute duration. So this is if you want your nap, that power nap scenario, you want it between REM 1 and REM 2. If you don't, you're going to wake up foggy. Okay, so that REM 3, REM 4, you get woken up by the kids at the wrong time, you're going to wake up foggy. If you go for a power nap on the weekend, this is the stages that you want to wake up. REM 3, this is deeper sleep, okay? So you start to get deep sleep, your heart rate and respiratory rate are going to fall at their lowest. Your muscles are completely relaxed, and this is the longest stage, and it is actually longer in the first half of the night. This is when you can sleep through. So if someone said to you, did you hear that thunderstorm last night, and you didn't, you were probably in REM 3, so the deepest stage of sleep, and you can sleep through noises up to 100 decibels. Which is absolutely amazing, because I went to a concert on the weekend and my watch went off at 95 decibels, and I don't know how I'd sleep through that. REM 4, that is represents the dramatic departure from those preceding stages. Our heart rate and blood pressure increase, our eyes start to move radically. The body goes into that temporary paralysis, which some people are quite mindful of, and they find it very frightening. So I suppose just putting it out to you guys, and you can, Helen showed me a little thumbs up reactor thing. So if you think you're a good sleeper, I can see there's 37 of you on board, but just give a thumbs up if you think you're a good sleeper. So it's hard for me to see, but I don't know if anyone, oh, there's 1, 2, 3, 4, 5. So that's not many of you. Either you're not using the button or not many of you getting good sleep. And it's hard for you to answer this question, but just have a little thought to yourself about what amount of hours you would think would be a good amount of sleep. And there's some science to it, so we'll talk to that. So this is from the National Sleep Foundation, and I put this graph up just because you may have young ones in your family, and you've got elderly people in your family, I'm sure. So across the generations, the dark blue is the recommended sleep time. But if we look towards the right end of the spectrum, which is actually, I'll go from here. So, oh, sorry, Doll, I was just going to point to. So 7 to 9 hours is the recommended amount of sleep for young adults through to older adults, okay? Now, it's not too bad if you have 6 and not too bad if you have higher, looking at the 9 to 10, but there are actually consequences. So let's have a look. This is, I found interesting. The Sleep Foundation highlights that studies show that sleeping less than 6 hours per night, there's a 20% increased risk of a heart attack. So you can think about that in your week. There's probably many a time when you've had less than 6 hours. So all of us, even with a healthy heart, we're increasing our risk for heart attack. So research from the American Heart Association, so that shows that maintaining a consistent sleep pattern will help prevent cardiovascular disease. It showed that if we fall asleep at different times, if we have the inconsistent amount of hours, just like I said, with greater variations than 2, will link to a developing risk of atherosclerosis. The other really important thing, which I kind of never was aware of until studying this, and it's been presented a few times, in fact, last week as well, is the importance of the dipping blood pressure at nighttime with good sleep. Poor sleep results in non-dipping blood pressure, and we have a higher risk of cardiovascular issues if we don't get that. So nocturnal high blood pressure is more predictive heart disease than high blood pressure during the day. So that's why in your clinics you might have seen your specialists switching times or maybe moving a medication to the evening. We do need that nocturnal drop in blood pressure. So let's look at some fun facts. If we can just grab a couple of these, you might be able to use them to motivate patients, which is what we're here for. So the Australian Institute of Health and Welfare, in 2016, nearly half of all Australians, so 48%, have at least 2 sleep-related problems. So that might be the fact that they simply have short sleep per age group, or they might have long sleep per age group, or they may have a poor quality sleep or a sleep disorder. In 2018, 25% of our 12 and 13-year-olds and 52% of our 16 and 17-year-olds don't meet sleep guidelines. So during the school night, they're not getting their adequate sleep. Women are more likely to get insomnia, and those who suffer from insomnia are 69% more likely to have a heart attack. And you know, there's a whole interesting presentations that could be done with women and heart illness, but insomnia plays a role. Men are more likely to have sleep apnea, which probably isn't surprising to most of you. There's a big study in Southern Denmark University of 300,000 adults. And that was combined with the University of Sydney, I should acknowledge. So poor sleep quality with disorders such as sleep apnea, that can increase a person's heart disease and premature death by up to 7 years. Poor general sleep, which I admit to having on occasions, particularly moving through the menopausal phase, can result in the loss of 2 years for both men and women with a normal heart. So if those numbers don't make you think about the importance of sleep health, I don't know what will. So with sleep, it used to be something we didn't discuss, and now it's becoming an important part of best practice. So in many countries now, instead of looking at an activity guideline, we're looking at a 24-hour health guideline. So that means that recommendations are now including, yes, activity, that's always been the case, but also screen time and sleep. Our Australian physical activity guidelines, they're also looking at that now, adding, limiting our sedentary time and optimizing our sleep duration. I hope I'm making sense. If I'm not, please let me know. So what we want to do is just look at sleep and health and how it affects all the systems. This is a very simple slide, but it just shows that's how sleep can affect every different system. And I'll go through a bit more in each detail, but we're starting with the brain. It impairs cognition if we're sleep deprived. We've all experienced that, I'm sure. Increases our symptoms of depression, our breast cancer risk, our heart disease, which we've already talked about. It can lead to weight gain with altered exercise and altered food choices. it increases our risk for diabetes, increases our risk for stroke, and increases anxiety. So all of us should be thinking about optimizing a sleep routine and getting those 7 to 9 hours. What I want to do is kind of break down our systems so that you can kind of see what's happening with each system when we have a sleep issue or sleep concern. So with blood pressure, during sleep, the body goes through that physiological process that helps regulate blood pressure, which I talked about before with nocturnal dipping. So poor sleep will disrupt that. And as we mentioned before, we get elevated blood pressure. Then we look at heart rhythm, breathing interruptions, so those apneic moments with conditions like sleep apnea, they cause the heart to work harder. So this leads an increasing risk of arrhythmia, classically atrial fibrillation, and it can potentially increase the risk of cardiovascular heart disease or coronary heart disease. Under the inflammation and oxidative stress, poor sleep has been associated with increased inflammation, and then that leads to a progression of our cardiovascular disease. Moving on to metabolic health. So with metabolic health, sleep's closely linked to metabolism, and in disrupting that hormone regulation, that affects our insulin sensitivity and our glucose metabolism. And so then we can kind of visualize that picture that then leads to obesity, type 2 diabetes, and a risk for higher cholesterol. With sleep issues, we then see an effect on lifestyle, and that includes its impact on our physical activity levels. So if we're tired, we may not get up to the gym. We can't be motivated after work to exercise, those kind of scenarios. If when you're tired, your dietary habits change, you may not be bothered cooking, you may go for an easier option. Poor sleep can lead to fatigue, a lack of motivation, those cravings for unhealthy food, as I just mentioned. And as we know in the cardiac rehab role, that all is relevant to our patients with cardiovascular disease. So what I want to kind of break up to now is a bit on sleep disorder. And sleep apnea is the classic one most of you guys would be very, very aware of. So sleep apnea, there's 3 types of sleep apnea. I certainly wasn't aware of the 3rd type until I started to look into this in a little bit more detail. As we will all appreciate, sleep apnea is a sleep disorder characterized by recurrent episodes of partial or complete cessation of breathing during sleep. This can result in a reduction in oxygen levels and disrupted sleep patterns. Apnea is defined as a ceasing of inspiration that lasts more than 10 seconds. So that's when the wife hits the hubby because there's this silence and they want them, and they take this big gasp, all right? So it has to be an apneic moment of greater than 10 seconds or lasting 10 seconds. Obstructive sleep apnea, now that's when the throat muscles relax and we block our airways. So that's when we're very conscious of a man with a very big neck or a woman with a very big neck. Central sleep apnea, quite frightening. This is when the brain doesn't send the proper signals to the muscles, and so we stop. We lose the control of breathing. I never knew about treatment emergent sleep apnea. This is a complex sleep apnea, and combining kind of the two, it's not something that I've seen in my clinical experience. 99% of my patients that I've looked after have obstructive sleep apnea. So being that it's the most common and something you might see in your clinics, around 34% of men and 17% of women live with obstructive sleep apnea. Researchers estimate 80% of the moderate to severe obstructive sleep apnea remains undiagnosed in the community. So being that you guys are running cardiac rehab clinics, you can be the one to pick that, and you may be the one to save someone and certainly get that investigated. 40 to 60% of our patients with cardiovascular disease have obstructive sleep apnea. If they do, they're 4 times more likely to have a stroke. They're 5 times more likely to have cardiovascular death. They're 5 times more likely to die of cancer. They're 2 times more likely to have depression. They're more likely to develop impairment, cognitive impairment, and develop Alzheimer's. So they're very scary numbers, but when you're trying to motivate someone to address sleep health, those numbers, if you keep in mind, might just help motivate that patient to get that addressed. So let's look at sleep apnea and then once again break down the systems. So cardiovascular wise, cardiovascular stress for sleep apnea. This episode of disrupted sleep, it leads to an activation of our sympathetic nervous system. So that's going to result in an elevated heart rate, an elevated blood pressure, which is putting extra stress on the cardiovascular system, which we now know and clearly know it increases blood pressure, increases arrhythmia, and increases heart failure. Under oxidative stress, the sleep apnea episode causes the inflammation and the endothelial dysfunction. And in sleep apnea, it affects insulin resistance and alters cholesterol. So some symptoms that show with sleep apnea: excessive daytime sleepiness, loud snoring, observed episodes of stopping breathing, abrupt awakenings. So that's when I talked about those 10-second moments. Often people awake with dry mouth or say to me they drink nothing during the day but a litre during the night. Waking with morning headache, difficulty concentrating, and mood changes like irritability, etc. I'm sure in your lifetime you've experienced caring for someone with all of those symptoms. So now, just to put a different slant on it, I want to talk about what the American Heart Association's called as the Life Simple 7. For all of us, that's just simply the cardiovascular risk factors that we're very, very well aware of. So they include exercise, diet, smoking, weight, cholesterol, blood pressure, glucose. All of that's not rocket science. But what's interesting is that in June of 22, the American Heart Association changed their teaching concept of Life's Simple 7 to Life's Essential 8. So I'm not sure if you're aware of that, but it is now part of the American Heart Organization's recommendations. It's going to be hard for you to see this, but I just wanted to kind of bring it to your attention. You could look it up under the heart.org Life's 8, and you'll just see down the bottom that's got the little bed image and it says get healthy sleep. So I'm sure in your clinics you've all been addressing those other 7, but kind of just putting it out to you guys. I can see there's about 40 people listening. Have you been routinely discussing sleep in your cardiovascular clinics? Just think about the answer of yes or no, and we'll continue on. Hi, Helen, are you talking to me?
No, I was just raising my hand to say that we talk about sleep. Yep.
You are talking about sleep?
Definitely.
Yeah. Is everyone talking about sleep? I don't know whether you can do that thumbs up again, or is this a new concept? 1, 2, 3.
More people doing that than sleeping well, Tracy.
So it seems it's quite a few of you. I don't think I can see what the total is. About 10 little thumbs up came up. I've got Glennis saying sometimes talk about sleep. I suppose if you just walk away from this now just thinking sleep is as important as blood pressure, I'm going to open this conversation up with everyone. Then this 45 minutes, Jill can't find the thumbs up button. It's up the top under react if you're looking for it. When you hit react, there'll be a few options and then you can just click that. So if we, as I said, this hour that you're giving us, if you think about adding sleep, then it's been worth it. So what this is random, absolutely. But what I find is patients come to me with lots of thought bubbles. They've got lots going on. I'll talk to that in a minute, Joanne. They've got lots going on and they don't know where to begin. All right. They've got, when should I get my cholesterol done? What should I eat? How should I exercise? What are these tablets for? And it's very, very confusing. So what I've designed and I use in my clinics is this concept of a cardiovascular risk factor wheel. So when I'm talking in a clinic, I work through and go through the non-modifiable risk factors with each patient, and then I come around every modifiable risk factor. If I was talking about blood medication like ramipril or atenolol, I'll pop it into the appropriate boxes. That way the patients start to realise this medicine is to slow this wheel down, is to reduce the chance of me having heart disease. Because the faster this wheel goes, the faster you're going to get heart disease. I have always included sleep, so I have this central section, and I address sleep health as we move through the circle. So I come around this way, and once we start getting to emotional health, sleep falls into a lovely conversation, because if we're sad, we might have affected sleep. If we're anxious, we might have affected sleep. If we've got a sleep apnea, we might. So we can then fall into this. So I don't know what tools that you guys use to help introduce sleep, but this is something that I've made that I find quite helpful. So what I would like to do now is just talk to a couple of case studies, which may be quite a difficult concept seeing that I can't see you, but we'll give it a crack. All right. So case study 1 is Mr. L. He's 70. He's got paroxysmal AF. In working out management of AF, we've done an echo, and the echo shows mild to moderate LV dysfunction with mild biatrial dilation. So then instantly in a cardiac rehab head, you're looking at a little bit of heart failure education. He's got an angiogram and required a couple of stents in his LAD and circ. And now he's for consideration of AF ablation. He's got high blood pressure, high cholesterol, diabetes, overweight, and sedentary. That's number 1. Number 2 I wanted to talk about was quite different. And that's a Mrs. E, 59 with SCAD. Troponin peaked at 11,872. The arteries look okay, but there was a possible SCAD down the diagonal too. All the other arteries are normal. Not really any risk factors. Bit of borderline blood pressure, borderline cholesterol, not overweight and very active. So let's do case study 1 first. The things that we would obviously go up and talk about in our clinic is all our modifiable risk factors. But I'm going to have to skip through this. I actually made some alterations, but it didn't change. So in the clinic, we're always involving our partners if we can. So that's something both of us or all of us probably do, because we get more information out of the partner. We discussed the modifiable risk factors, which we don't need to go into because we're concentrating on sleep. With this person, you can actually visualize him. He's overweight, he's inactive, he's got lots of risk factors. Our wife's there. This is a great opportunity to assess sleep. And I'll go through some questions that we can ask for that. With this patient, we're going to encourage attendance to the exercise, to the education, and we're going to encourage discussion of a sleep study, and I'll explain why. Some of the questions you might be able to ask for this patient, simplified, or do you snore loudly, making choking or gasping noises like we discussed before? Do you have interrupted sleep? Does your wife kind of hit you when we kind of ask her if she's present? Do you feel excessively sleepy or fatigued? Do you wake up with a headache like I mentioned before? Have high blood pressure or heart disease, obesity, risk factors, etc.? So someone's already mentioned, but what we do in our cardiac rehab clinic is the stop bang. Is everyone using stop bang already routinely in clinics? If you give me a thumbs up, if it's something you're very, very familiar with. I just got 3, 4, 5, 6, 7, 8, 9. So there's 36 on board. So be interesting if maybe if there's a few crew that didn't say yes, then you walk away thinking, oh, I might add a stop bang to my clinics, then that's a positive thing. Stop bang's really easy. It looks at snoring, tiredness, observed apnea, high blood pressure, body mass index, age, neck circumference, and gender. So you simply just give it a yes/no answer. You add them up, you get a score. The score is low risk 0 to 2, intermediate risk 3 to 4, and high risk 5 to 8. So if we're doing that, we have to be mindful of the outcome of that. Obviously, if you've talked about sleep apnea in a clinic, you're going to write a letter to the GP. You can put what clinical presentations they have that made you think you need to do a stop bang. You can give the stop bang description, so intermediate risk or high risk, and you could suggest a sleep study or have that ask the patient to have a conversation about sleep. Just be mindful of a patient's profession. I wouldn't want you to put the stop bang high risk in a letter if the patient is a bus driver or a commercial driver, because what if that was wrong and he had a sleep study, it was negative, and you'd said it's high risk, and I would hate that to influence his profession. So I'm kind of conscious of that when I'm doing these assessments. You could even print it out if you were concerned like that and give it to the patient to take to the GP if that was a concern. It sounds like you guys are using that. There is other options. I just use stop bang because I find it easier. But there are other questionnaires. So the Berlin questionnaire, the Epworth sleepiness scale, and the Athens insomnia scale. These tools use different formats and assess different sleep apnea symptoms. And the choice may just depend on your clinical setting and your patient population. But for the simplicity of the stop bang, that's certainly my preference. Epworth, some of our team have used in the past. Is anyone using Epworth? If you thumbs up me. One. Did you, Helen, just put something on up then? Was that for everyone, Helen?
Yep, that's just if anyone needs to find the stop bang, it is a validated tool, and that's the research.
Oh, thank you. I was going to put that on. Yeah, awesome. Thanks. So yeah, like I said, my goal today would just be that you take away with one thing. So if you've never used one, maybe you could do that. So let's look at case study 2. Now, this is quite different because people are like, why would you present SCAD with sleep? And that's because sleep is not only a physical issue, but an emotional issue. And that's often something people don't feel confident talking about. So this patient really doesn't have much of a risk factor chat. Oh, what's Joe saying? We do a stop bang so we can, sorry guys, I can't quite read them when you're typing, so I'll keep going and we can bring those up at the end maybe. So if I'll just ask you, you can do that simple thumbs up again. If you had a SCAD patient, would you talk about sleep routinely? So I've had about 8 people say yes. I'm going to go through why I would, I suppose. So obviously I'm going to use that same concept with that risk factor wheel. And we can reassure the patient by the fact that, look, your blood pressure is really good, this is really good, and move through. And when I get to the emotional well-being of the patient, I'm going to do a HADS score. Does everyone use HADS for emotional? So HADS is hospital anxiety and depression score. Yeah, so I've got one person Joe's using HADS. So I do a HADS score to assess anxiety and depression. And with SCAD, it's a very frightening disease. Patients feel like they've lost control, and anxiety is very, very common. When I did the HADS score on this patient, it came up at 16 out of 21 and depression 3 out of 21. This patient's not sad. She's frightened. She was a very, very big businesswoman who flew around the world, had a lot of staff underneath her, very independent, went very remotely into Africa and things like that. What happened was this patient lost confidence with her heart, and it gave her anxiety that there was very little they could do and it might happen again. So with that in mind, what's going to happen? Anxiety is a classic thing, and when it rears its ugly head, it's usually at 2 o'clock in the morning. And so then what happens is that our patient have ruminating problems and negative thoughts. So that a lot of this consult with a patient went around sleep hygiene and management and sleep techniques. So just kind of a few extra bits there, that the average person has 6.5 thoughts per minute, 6,000 a day, and 80% of them are negative. So that's on an average day for most of us. When you've had something else happen to your life, that negative is even going to occur, more than that. I'll go through them in detail, but what I did in the clinic was the importance of talking about managing rumination and negative thoughts, which I'll talk about how I did that. Gratitude, empathy, and mindfulness, which is the GEM series of life. Talked about some breath work, talked about journaling, did a mind spot referral and a psych referral. This patient then needed confidence with exercise, so linked into the exercise program and attending the sessions, of which you really only wanted to attend stress and exercise. So the risk factor wheel came in handy again. When we think about sleep quality, relaxation therapy, psychotherapy, and complementary medicines are something we could all think about. So some sleep tips we could give to this patient, sleep tips for all of us, knowing that we want to hit that 7 to 9 hour, is keep good sleep hygiene. And I've got a slide to follow which will simplify that. We all know it, we just kind of see it on the slide though, but developing strategies for relaxations, breath work, which we'll talk about, yoga and mindfulness. Keep a sleep schedule. So for this patient, we had to reset that because she was too scared to go to bed because she was too frightened it was going to happen. And when we get that anxiety, it's very hard to calm. Just make sure your bedroom is accommodating to good sleep. So a nice friendly environment, dark, cool and quiet. We do sleep better when we're cooler. That's harder in this type of temperatures we've been having, and if you're not blessed with air conditioning, etc. Getting enough natural light, which we'll all be mindful of, just having the blinds slightly open and waking to natural light. We should avoid artificial light a few hours before bedtime, which we're all mindful of, and we know that our devices are causing significant problems in the community. We need to stay away from the negative influences on sleep, so avoiding caffeine, nicotine, and alcohol in the late afternoons. So, no coffee after 2 or 3 would be ideal. If you have one to get through the afternoon, you've probably still got that. I know I don't have coffee, but caffeine sensitive, and I used to be able to do a night shift on 1 coffee. So you've got to think about your patients and maybe they can revisit their caffeine habits. Don't force yourself to go to sleep. So with this patient particularly, we don't want them to go to bed. What happens classically, go to bed, fall asleep well, wake up at 2 for a wee, go to the toilet at 2, come back, look at the clock, it's 2 o'clock. Then what was happening with this patient is toss, turn, recheck the clock. When they recheck the clock and it's 3 a.m., they have an adrenaline drive. This lady was a busy businesswoman. Okay, so what's happening with that is she thinks it's 3, she's lost an hour's sleep, and now she's anxious. Now she's thinking, I've got a big day tomorrow, I've already lost an hour's sleep. So if you take away one thing, get your patients definitely not to clock watch. Tell them to be reassured that they will sleep. When your body needs sleep, you will sleep. It's something that's why it's torture. We can't stop sleeping all the time if you need it. That's why sometimes people go, oh, I had a good night's sleep a couple of nights ago, because if you need it, you're going to get it. But just stepping away from the bedroom, if you're tossing and turning, resetting and then going back to the bedroom is a good idea. We don't want that to be an anxious place where we're going over and ruminating scary thoughts. This is a nice quick slide. Let's clean up your sleep hygiene. So it's just through heart.org, but it just says move it, dim it, set it, lock it, block it. It's quite a good slide, which basically says everything I just said on that previous slide. So might want to look at that through the American Heart Association. So let me just go through some breathing exercises I went through with this patient. So we talked about diaphragmatic breath work and belly breathing. And the really important one that we talked about was the breath work of 4, 7, and 8. So to simplify over this kind of teaching tool, what we always want with our patients is that the exhale is longer than the inhale. So whatever they're able to do, even if it's 3, 4, 5, the last number should be longer than the first number. Okay, so we want to make sure when they take a breath and they hold and then they exhale slowly for a longer period of time. Now that's going to stimulate parasympathetic systems. So that's going to calm the farm, which is what we want. So we want to calm everything down. So just doing that, you can do about 6 in a minute, or 10 cycles, 6 in a minute, 6 to 10. The other one that I use quite a lot is a count back from 100. So what I find is our patients come with 1 trillion thoughts, okay? So they come like having 1,000 twinkling stars and they've all got a thought attached to them. So when they go to bed, all of those thoughts start coming. And what we need to do is get our patients to quietly turn the lights out. And how we can do that is teaching them a count back from 100. It can be a count back from 20, it doesn't really matter. So if we get the patient to start counting back while they're nicely breathing and exhaling slowly, every time a thought bubble comes, they have to reset. So when they go 100, 99, 98, 97, I wonder if I get scared again. Reset. 100, 99, 98, 97, 96. I can't believe I got, I'm still awake. 100. So what you can see and visualize is every time they do that, the thoughts is getting darker. So if you've ever, I use it quite a lot for myself. And when you're doing that, it kind of makes things more peaceful. And all of a sudden it's gone from a bright, twinkling 1,000 stars to a very peaceful and darker, and then you're off to sleep. Journaling is a good thing, and positive affirmation. I got my patient to write an affirmation by their bed so that when they woke up, their first thought wasn't negative. Sadly, in our world, we wake up with Siri going, speaking to you. You pick up your phone to check if there was any emails. You realize you didn't answer it yesterday. There was a message from the kids, and it's instantly negative. With so many negative thoughts in the day, by just having their affirmation by their bed, at least they're starting the day with something positive. Whether it's my heart is fixed, I have a good team, I trust my team, I trust my heart, they can make up their own affirmation, okay? So with this patient, we've done breath work, we've done the count back system, we've done positive affirmation, we've done sleep techniques. Journaling is great. People find that good and bad. Some people are frightened of what's going to come out. They can, if you put pen to paper and scribble, it doesn't have to be readable. It's just that pen to paper technique. There's also some evidence around burning it afterwards. It's kind of releasing all of those bad thoughts. Another technique I use, I don't even know where it ever came from, is I get my patients like this to score their day out of 0 to 10. So 0 is a bad day, 10 is an awesome day. This kind of person who's a businesswoman who needs to see they're moving in the right direction. If your day is good, it's a 10. It's not rocket science. If it's bad, it can be, 0 or 2. But what I get the patients to do is score and write what's something next to it. So if it was a 9 and they saw the grandkids, or a 9 and I went for a run, they'll start seeing what strategy made them feel good. And when they put that together, they can just put it in their phone. It's like they can graph their emotional health. If they see that they're still stuck on 2s all of the time, they might then want to go and initiate some more emotional support with their GP, to get a psychology review, or have a chat to someone and touch base with the cardiac rehab team saying my emotional health isn't moving along. The other side of that is they might say, oh, I actually had a couple of 7s and 8s last week, and then keep tracking it, and they might see that their graph's actually moving up and their emotional recovery is going in the right direction. So I found that little technique quite helpful for people that want to see where they're tracking, because as humans, we're very good at remembering the bad and not very good at remembering the good. Okay. Body scanning, autogenics, all of that, self-hypnosis, are all techniques that you would have heard of in the past. I suppose we're going to finish a bit earlier, but it's hard when we're not interacting. Just that I'd love it if you consider discussing sleep with your patients now after having a bit of a chat. There are lots of links within my presentation, the Heart Rhythm Society, Upbeat, Sleep Health Foundation, the AF Health Direct, Mindspot, Beyond Blue, that are all great resources for sleep. And Alan Reichschaffen was very famous. He was a sleep researcher pioneer from 1927 to 2021. And his lovely quote says, "If sleep does not serve an absolute vital function, then it's the biggest mistake the evolutionary process has ever made." So I hope we got something out of that. As I say, it's the first time I've presented without seeing humans, really. So if you've got any questions, I may be able to help you or certainly direct you.
Fabulous presentation. Thank you so much. Taylor, can we make sure everybody's mics are unmuted? Thank you. That was fantastic. I do. I love my REM2 sleep.
What was that? Sorry.
I love my REM2 sleep. I do that every night and then take myself to bed for the to get into the not hearing the thunder and lightning.
Yeah.
So yeah, that's great. But the big one for me is that motivation. If you have a bad night's sleep, I mean, cognitively you're tired anyway.
And I suppose if the scenario in that presentation, I just wanted to say it doesn't matter. So I gave a SCAD and our normal kind of heart disease AF patient, you know, it's important for both, but quite different reasons. So when you start pulling history, you start seeing that it's affecting a lot of us.
Yeah, and yeah, it doesn't really matter what disease you have. The fact that you're interfering with your blood pressure, you're not allowing your blood pressure to go down, so then you're shifting adrenaline and cortisol, and that damages every cell in your body. So not having good sleep is just really gonna affect your cardiovascular health. And if you already have had a cardiac event, that's just going to make things way worse. I love we have 6.5 thoughts per minute, and 80% of them are negative.
Isn't it sad?
I couldn't believe that. That blew me away.
Yeah,
Tracy.
negative and repetitive, because a lot of us will just rethink the same negative thought on multiple occasions a day. So we've just got to try and get all of us, which comes into the GEM theory of life: gratitude, empathy, and mindfulness. You know, just being that 3 grateful things a day. There's a lot of power in that. So that's what journaling, just writing 3 things a day. You know, having a little grateful jar that we put those 3 things for day, and, you know, bringing that at the end of a month and going through them with your family of what you're grateful for. Getting a little jar by the coffee machine and write what you're grateful for. It can be as simple as a good avocado because you paid $2. It can be as simple as that, but it's putting that positive spin onto what we always considered all the negative stuff.
Yeah, and doing that in the workplace is a great thing. I've done it in more places.
Actually, that's a good idea. I might get a jar
really good thing
for the cardiac rehab team who are exhausted.
Yeah, because you also tend to put really nice things about each other, which is always great, especially if you're having all those negative thoughts. That's really now really important before not that we're going to leave yet, but if you could complete as you leave the room, there are 6 very, very quick questions, and they influence what we can present next time. So we want to present what you guys want. But I really want to, has anyone got any questions for Tracy? I know in the chat there was.
Yeah, you can always just email me if you need something.
Yeah.
I'll just ask you guys, do you think you'll talk about sleep in your cardiac rehab clinics now?
You should be thumbs up everywhere.
Yeah.
Here's a question. Joe, I feel very equipped in identifying, but really struggle talking about insomnia. Any pointers there,
Well, that
Tracy?
goes back. You've got to work out why they've got insomnia,
Yeah.
which usually is because of rumination, which is what I was like. That's why I talked about managing rumination, because what happens there, and a lot of them just wake up and then they just spiral into this thought process, which keeps them. I mean, it is scary, and insomniacs is very, very, very scary. But I don't know much more than that on that particular subject. But insomnia related to anxiety and rumination, I feel comfortable talking about that. If they're diagnosed as insomniac without an emotional component, I think that's a sleep specialist. That someone's got their hand up, I think.
Yeah, can you come off mute, Suzanne? Are you able to come off mute or type in the chat? Are you happy to share your slides, Tracy? Yep.
Yeah, I can just, it's probably too big to slide. I can make it into a document and then send it probably.
And you can look at Taylor has been recording, so.
Oh, there you go.
Yep. So the recording will be available. Suzanne, you can't come off mute. Taylor, can you get Suzanne off mute? No? Disabled.
She is able to come off mute.
Yep.
I've allowed her mic.
Okay, cool. Suzanne,
the questions come up and they just disappear in 30 seconds, but someone said that they do screen routinely, which is awesome. But I couldn't say it said, because then what's quite frightening being in the role of our role was that you identify an issue and then you write to the GP, and then you're very dependent on the GP and their 10-minute consult, reading that letter and acknowledging that sleep or that question, or the patient having confidence to bring up that topic as well. So when I write, I always write to the consultant and to the GP. But one of our consultants, who is the AF specialist, is doing research called Stop Bang, not called Stop Bang, called Snore, and it's trying to look at the relationship between AF and sleep apnea, see if there is a relationship. Because you think about it, if you've got obstructive sleep apnea, you're 140% more likely to get AF. You're 30% more likely to get coronary heart disease. But, they're pretty significant, that's for sure. Susan's still got her hand up.
The original publication for Stop Bang, I really am not a researcher in any shape or form, but if anyone wants to look at it, I was one of the authors of the original back in 2016, which has now been validated.
I just saw a Di put there that they include sleep in their education sessions, and I certainly do as well. So in that, our sessions are Monday night, but we do cover sleep.
Great, good. And would you cover it as part of a stress?
Part as a risk factor talk,
part of the whole risk factor talk.
Yeah.
And the other interesting thing was, I know you use the HAD score, but different facilities use different scores.
That's what. And Epworth's pretty popular.
And the PHQ and GAD scores and K10s and
that's the emotional component. We find the simplicity of HADs quite good, that patients don't like those big long questionnaires.
I think ACRA, if I looked at I haven't got it, I'll Google it, the quality indicators, does it specify a score to use? I honestly don't know, but
I
I'll
don't know.
have a look.
I was just looking
Yep.
through questions now, Helen, and because I couldn't see them when I was doing the presentation,
Yep.
but Joe was very fortunate enough that they can get a stop banging the ESS and send patients straight to a sleep study. We certainly in the private world don't have that opportunity. We can suggest, but we can't go and say, go and have a sleep study. We have to go through the process of writing to the GP and getting them to arrange it or highlighting it in the letter and hoping that they will.
Yeah, great if your in-house can do that. It's similar for referrals for depression and anxiety as well. Often public hospitals do have, you can send a direct referral, but depending on, and in the country areas that, may not be so easy either. Yep. Yeah. The other part that I was really interested was the treatment emergent sleep apnea.
As I said, I hadn't even heard of that until I was looking into it.
Yeah. But treatment for
that's just the name of it. I honestly don't, as I said, not a sleep guru. 99% of my patients have obstructive sleep apnea, but just in researching it, I found that there's actually 3 types, which I'm sure if they went to a sleep clinic and had a sleep study, they're going to be diagnosed clinically properly, and then the management would be up to a sleep physician. But in the clinics, most of mine's obstructive sleep apnea.
Yep. Well, if there's just see if there was any other questions.
I've had a look. All of them have. There's no more.
Been answered. Good. Yeah. Well, thank you very, very much. That was fabulous. Lots of great practical advice and a great case study. So thank you again, Tracy. And
no worries.
if everyone, can complete the questionnaire, that would be great. Thanks for attending.
All right, team. See ya.
Bye.